Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We have a Telegram group. You can join this group for accessing all lecture related information. We have a Google Drive where the PDF of all lectures are uploaded. You can access them freely. We have a master integration key by which you can navigate between the PDF and the YouTube. These are the disclaimers. And we are with phase 3, which is recorded pathology lectures. Today we have Pursue 3N, which is soft tissue and bone tumors, and we are streaming live from Kolkata. The topic of the day is Bone Pathology Session 6, which is approach to small round cell tumors of bone and soft tissue. To talk on that, we have Dr. Bhaskar Mitra, who's an MBBS from Calcutta, MD, DNB Pathology, a gold medalist, a consultant histopathologist at the famous Tribedi and Roy's Diagnostic Laboratories, Kolkata, with multiple publications in indexed national and international journals. He's been the advisor of clinical research at the School of Medical Sciences, IIT Kharagpur, and has multiple publications, reviewer of various journals, member of the IAPM as well as CAP. With this, I would request Dr. Bhaskar Mitra to start his talk. Thank you so much.
Good afternoon, everybody. In the series of bone pathology lectures, I am coming to the end of the lecture of this series. Now, today I will be going to discuss about the small round cell tumors of bone. Now, there is a disclaimer to my lecture is that small round cell tumor of the bone is not a single topic. It encompasses also the soft tissue part of the tumor. So it is mainly the approach to the small round cell tumors of the bone and soft tissue. As a resident of the pathology, I always found it is very difficult and it is always a nightmare to every pathologist to detect the which type of small round cell tumor it is, because all looks very undifferentiated. Whenever that this type of slide comes to us, we are always having nightmares. Now, tomorrow what diagnosis we will offer. Now, there is a general approach to this small round cell tumor. First of all, we have to know what is small round cell or what is the definition of this small round cell tumor. This is a group of highly aggressive malignant neoplasm which are composed predominantly of the small round monotonous undifferentiated cells having high nuclear cytoplasmic ratio. The size of these cells are larger or double the size of a red blood cell at least. So small round cell tumor doesn't mean it's a very small thing. It's a quite sizable thing. So this is the long list of small round cell tumor. It almost all looks same, whichever Ewing sarcoma, pinnate, rhabdomyosarcoma, small synovial sarcoma, lymphomas, all type of blastomas, they all comes into the general group. Or there are some very undifferentiated groups, sometimes granulocytic sarcoma, intra-abdominal desmoplastic small round cell tumor, all comes into this group. So we first have to know what is the basic details of these tumors. Then we will have a algorithmic approach to this small round cell model. First, the diagnostic approach, we all require the clinical findings, which we very less we get. We only get the demographic things like the age, sex, site, and the clinical presentation. Almost in all of the cases, we doesn't got this. Radiological finding is very important to determine the exact epicenter of the lesion, whether it is a pure bone lesion or a soft tissue arising lesion involving bone or vice versa. Then comes the pathological findings, which is in our domain, followed by a group of immunohistochemistry tests to determine what is the nature of these cells. And final what was written by this molecular genetic people. They do the FISH, RT-PCR, even the flow cytometry. By using this technique, they find out what is the genetic thing in this disease. Now, how the small round cells look like. Cytologically, these tumors are composed of nearly uniform population of round to oval cells having scanty cytoplasm, scanty basophilic cytoplasm, mixed population, and there is a mixed population of small to large type of cells. So whatever we see in the slides is mainly the nucleus, and the nucleus is basophilic or the bluish in nature. So we will see the small round blue cells in throughout the slide. Sometimes they are synonymously called as blue cell tumor of the bone and soft tissue. Now they have 3 times or the size or diameter of the small mature lymphocyte. I have already spoken about this. They have a single hyperchromatic nucleus having finely granular chromatin. Nuclei usually not apparent in most of the cases. Cytoplasm is generally scanty. Sometimes you can see clear to vacuolated cytoplasm in some of the cases. So these are the plethora of these small round cell tumors containing those blastomas, neuroblastoma, nephroblastoma, retinoblastoma, Ewing's pinnate group and the Rhabdomyosarcoma group. There comes the again group of blastomas like hematoblastoma, pinealoblastoma, medulloblastoma, lymphoblastic lymphomas, then the soft tissue part. So in this lecture, I am not going to tell about all those blastomas. I will touch about the some of the important blastomas, one or two, but not the all. I will concentrate on my lecture only on the small round cell tumors of bone and soft tissue. This is the old classification where we got the CNS peanuts, the neuroblastomas arising from the autonomic nervous system. There is the Ewing sarcoma, malignant peanuts, and the Askin tumor. So first, the most common thing is the Ewing peanut group of tumors. It is usually a tumor of the children and most commonly affecting the males. They mainly affect the medulla of the diaphysis of these long bones. They involve the soft tissue of the extremities. Clinically, tumor may simulate like a inflammatory osteomyelitic lesion. So it is very important to have a good eye to and suspect that this is a case of small lines tumor, not a osteomyelitis. There is widening, radiologically we will get widening of the medullary cavity with the cortical thickening at the places. There may be onion skin appearance of the periosteum, and there is always sunray appearance of the periosteum we can. So, primitive neuroectodermal tumors or prenates are the small round cell malignancy arising from the migratory neural crystals, and it mainly affects the soft tissues. Now, they may affect the thoracopulmonary regions, naming it Atkins tumor. There may be extraskeletal Ewing sarcomas. There may be neuroblastomas, peripheral neuroblastomas. These are different things. Currently, they share the common cytogenetic and the morphological variety, so they are collectively termed as EWS finite group of tumors. And one thing most important, they are the most undifferentiated tumor. So my first category of this tumor comes the Ewing sarcoma and so-called Ewing-like sarcomas of our bone and soft tissue. They mainly arises from the bones, extraosseous areas. They may be arising from the chest wall areas. Children and the young adults are the most affected. Diaphysis is the most common site. They usually present an ill-defined osteolytic lesion. Now comes the common genetic abnormality among this tumor. This tumor has got a gene fusion transcript material. They have got a transcript from the TET or FET family of genes which associates with a transcription with the ETS family of the transcription factor, giving rise to these undifferentiated tumors. So most of them are, so there may be one gene from this state or FET group. Most commonly we found EWSR1 group, and the ETS family of transcription factor. Among this, FLY1 is the most important. So the most 85% cases we found the EWSR1 and the FLY1 fusion transcript in most of these cases, followed by EWSR1 ERG transcript groups. This constitute about 10% of these cases. Then comes the EWSR1 with non-ETS family of tumors, where we can found the other ETS groups like ETV1, ETV4, FEV1. This group of tumors comes into in this category. So there are the different partner genes for this EWSR1. There may be FLY1 transcript, which most commonly found in 80 to 90% of the cases. There may be ERG transcript giving rise to EWS ERG transcript in 10% of the cases. There may be EWSR1 ETV1, which is very rare. There may be ETV4 transcript and FEV1. These are the last three are the very rare ones. But what here I try to highlight is that there is a formation of one type of gene and another transcription factor gene giving rise to this fusion transcript, which helps in the differentiation of these important factors. So this is the most common thing, that the EWS chromosome and the FLY1 chromosome, and they combines together and form this transcript, and which is responsible for this Ewing sarcoma group of tumors. There may be other non-EWS1 group of tumors like CIC DUX4 sarcoma group, and we will coming to details of this today. So first is the Ewing sarcoma, or where we can find EWSR1 and ETS fusion transcript. As I previously said, the 85% are the EWS FLY1 group along with the EWS ERG, followed by the FEV, ETV1 and other group. They are called the Ewing's and Pinhead group of tumors, which we commonly find. They usually come CD99 positive. In FNAC, we will see the uniform sheets of the cells, very small, tightly clustered. Nuclei may be round, irregular, usually lack the nucleoli, having high nucleocytoplasm ratio, and it looks like large chief cells. There may be small dark cells and the small pale color cells in these tumors. There may be pale blue cytoplasm, they are containing variable amount of punched out vacuoles, which corresponds to the glycogen deposits. So if we stain these tumors with the PAS stain, then we will find the magenta color vacuoles are highlighted in this tumor. This is the histopatological picture of EWS-F1. This is the gross picture showing the medullary cavity widening, thickening of this cortex, and this diaphysis part is involved, and here lies the small blue round cell tumor, very scanty amount of clear cytoplasm around the cells, but most of this are hyperchromatic cells. Now there are three things in the Ewing sarcoma morphologically. First of all, we commonly see the solid sheets of uniform small blue round cells with a scanty clear to eosinophilic cytoplasm with a very minimal amount of extracellular matrix. Mind this point, there is a very minimal amount of extracellular matrix. Followed by, there is a group of atypical Ewing sarcoma, where the cells comparison to the classical Ewing sarcoma are a bit larger and more pleomorphic. The classical Ewings, the cells are more monomorphic, and same time here the tumor cells are a bit more pleomorphic. And there may be adamantinoma like Ewing sarcoma, where we can see lobules of this primitive small round cells surrounded by a bands of fibrous tissue. So atypical Ewing's group have a irregular coarse nuclei, more prominent nucleoli, and a moderate amount of glycogen containing cytoplasm. And for the pinhead groups, they have got the more amount of the neuroepithelial things like the neural tubules, neuritic process, these are common. This is the photomicrograph showing the patch staining of this small round cell tumor, showing the beautiful magenta color positivity on this scanty amount of cytoplasms. So these tumors are most commonly stained with the CD99. There may be also associated with neuron specific anomalous, neurofilament, vimentin staining and these tumors. Regarding CD99, one of my teachers always tell don't rely on the CD99 state because it comes positive in 99 type of tumors. Not 99 but it's a quite good number of tumors comes positive with CD99. So it will not help you to differentiate among the small round cell tumors, not even into categorize it as a small round cell tumor. Here is a list showing some of the normal physiological things which normally stains with the CD99, starting with the cortical thymocyte, Sertoli cells, endothelial cells, pancreatic islets, ependymal cells, urothelial, squamous epithelium and the columnar epithelium sometimes stains with the CD99 stain. This is a very catch questions for the PGTs in the Viva. They commonly ask which are the normal structure stains with CD99. Now there are the list of tumors. I mentioned very small list. Among this Ewing definitely comes lymphoblastic leukemia, synovial sarcoma. There is a long list goes on. There are other markers like S100, NB88 which also comes positive in the Ewing sarcoma. Next comes the most important commonly used marker nowadays is the NKX 2.2. It is a homeodomain containing transcription factor having neuroendocrine and the glial differentiation. They mainly targets for the EWSR1 and FLY1 or EWSR1 ERG gene, distinguishing it this Ewing sarcoma from its other histological mimickers. So CD99 along with NKX 2.2 will help you ensuring that this tumor is a Ewing's group of tumor, and this is a corresponding genes for the E1 and E fusion genes. Now the final diagnosis will be offered only by the FISH study where we can see the fusion transcript on the FISH, the comparison, the red and green component in the fusion transcript. There comes the yellow signals which is brilliantly seen in RT-PCR. Even in the FISH technique we can demonstrate these things. Now comes the first group we got with the Ewing sarcoma ETS family group. Now comes the EWSR1 or Ewing sarcoma non-ETS fusion. What I have previously told, there may be the other factors that comes into the play. Here comes the INFACT C2 which there may be association with this EWS non-ETS group. And among this INFACT C2 and first INFACT C2, these are the sarcomas of the bones. EWSR1 PAT Z1, it is the mostly involving the deep soft tissues of the different body extremities which usually have a unfavorable prognosis. Here we can see some amount of stromal matrix component which was not seen in the classical EWS ETS group of tumors. So first of all, this tumor cells has got a round to variable epithelioid morphology. They has got CD99 positivity and the PAC7 overexpression among these tumor cells. And they usually resist the normal Ewing sarcoma regimes of chemotherapy. So it is very important to identify this group of tumors. So these cases usually don't comes with this NKX 2.2 positivity. Next comes the CIC rearranged sarcomas. As our previous slide I have shown, there may be ETS, EWSR1 and the ETS or non-ETS, or there may be other group very less frequently we find, that is the CIC rearranged sarcomas. In the CIC rearranged sarcomas, these are the undifferentiated round cell sarcomas that clinically and histologically mimic the Ewing sarcoma but fail to demonstrate any molecular cytogenetic abnormalities among this. The translocation is translocation 419 with having the CIC and DUX4 fusion genes. They usually negative for the EWS fusion group of genes. They mainly involve the deep soft tissues of the limbs and the extremities and having an aggressive outcome. This tumors has got a small round cell tumors with a variable amount of myxoid stroma with a lobulated appearance. There may be some degree of nuclear pleomorphism. I am showing you the histomorphological pictures. They show variable expression of CD99 and WT1 expression along with the NUT expression. There may be other things that may be positive with the cytokeratin S100, but they lack the NKX 2.2. So that is the important factor to differentiate it from the ETS group and this CIC rearranged group. These are the cells, a bit round to oval cells, an aggressive kind of necrosis, and the apoptotic bodies and the necrotic things are there. There may be some amount of stroma which is usually lacking in the classical Ewing's group. Next comes the sarcoma with the BCOR genetic alteration. There may be the undifferentiated round cell sarcomas having the BCOR and CCNB3 rearranged things. They previously are called the Ewing-like sarcomas. They mainly affect the bones of the children and the young adults. They have a classically round to spindle-shaped cells with a hemangiopericytomatous appearance. This is the classically we can see the spindle cells along with a typical hemangiopericytomatous blood vascular arrangement in these tumors. There are the cells are a bit of epithelioid to small cells arranged in holes at places. So it more look like a spindle cell tumor than more of a round cell tumor. So a small round cell tumor having a generalized look of spindle cell morphology, we have to think of non-EWS R1 ETS group. Among this most commonly comes this BCOR family. Now these tumors are usually positive with the BCOR group of expression. It's a nuclear factor. Along with this they may also express the SATB2 or the TLE co-expression among. So this group till now I have discussed about the Ewing family of tumors, among which there are the Ewing and ETS family of group. There may be non-ETS group, there may be CIC rearranged sarcomas, and there may be BCOR rearranged sarcomas. Now among all these things, apart from the last one, most of them doesn't contain a significant amount of matrix material. So now if we get a small round cell sarcomas with a prominent matrix producing cartilage or bone, then we have to think of other tumors. So my diagnostic approach starts when we see a small round cell tumor. First of all, I have to search for the matrix, keeping about those molecular things. If we get the matrix, then my algorithm shifts to this group. If doesn't get the matrix, then the previous group. Now coming to small round cell tumor having the cartilage or bone matrix. Here comes the first differential. If we get a clear osteoid among this as shown in this picture, then it is a small cell osteosarcoma. It is an osteogenic sarcoma consisting of the sheets of rind cells that produce the osteoid matrix. Morphologically, it may sometimes look like an Ewing sarcoma when the less amount of osteoid is visible among this. They variably express CD99, rarely cytokeratin EMA, but they usually comes positive with the SATB2. But the diagnostic point in these cases are the presence of osteoid material at very. Next, if we see a tumor with undifferentiated component along with presence of a globules of cartilage, then we have to think of this mesenchymal chondrosarcoma. It is a biphasic tumor having a primitive round cell and well differentiated hyaline cartilage at places. They mainly arises from the bone and even in the extraskeletal tissues. The meninges, one of the important area, they may show hemangiopericytomatous like growth pattern. As these things are showing cartilaginous tumor, actually it is a cartilaginous tumor or the chondrosarcoma. That's why they comes positive with the SOX9. And as like small cell osteosarcomas comes with SATB2, here it comes with CD99 and SOX9 positivity. There may be recurrent transcriptional transcript, and these tumors are having very aggressive behavior. Next comes if we find any myogenic differentiation among the cell. Here comes the most important small round cell is the rhabdomyosarcoma. It is a large category of subtissue sarcomas of the children and young adults having a small round cell morphology. There are following types of rhabdomyosarcomas like the embryonal, alveolar, rarely spindle to sclerosing rhabdomyosarcoma. There may be pleomorphic rhabdomyosarcoma. These are the cytological pictures showing the nest and the loosely cohesive clusters of these densely packed hypercellular areas. This is the gross picture of this group of rhabdomyosarcomas. Now first comes with the poorly differentiated embryonal rhabdomyosarcoma. This is composed of sheets of small round to spindle shaped cells with hyperchromatic nuclei, and most of them having scanty cytoplasm. They having high brisk mitotic activity. Focally we can see the presence of rhabdomyoblast with abundant eosinophilic cytoplasm showing a striation in this cytoplasm signifying the myogenic differentiation of these tumors. These tumors are the granular, stringy, fibrillary eosinophilic material. In the picture, we can see the large cells, the rhabdomyoblastic cells, everywhere. Sorry. Again, there may be the features of anaplasia at places. Anaplasia means the large hyperchromatic nuclei, 3 times size of the neighbor as the criteria of the Wilms tumor, with or without atypical mitotic figures. There may be embryonal cytomorphologically, there may be different chromosomal abnormalities we can see. Now comes the immunohistochemistry part of this tumor, which is most important in these cases. They usually comes positive strongly with the desmin along with the other myogenic markers like myogenin, myod1. Sometimes aberrantly may express cytokeratin or S100 protein. So myogenin, myod1 positivity and the desmin positivity signifies this one as a myogenic tumors or the rhabdomyosarcoma. Abdominal rhabdomyosarcoma sometimes show a peripheral condensation or the cambium layer appearance. We can see in this picture a fair number of mitotic figures among this. It's a very aggressive and highly proliferating tumor. Next comes the alveolar rhabdomyosarcoma, where we can see typical alveolar pattern. I am not going into the details of this, but few things I like to highlight. It is the typical characteristic patterns of the cellular aggregate surrounded by hyalinized fibrous septa containing different blood vessels. There may be strong positivity for myod1 expression among these cells. They are showing this myogenic differentiation, and the rhabdomyoblast atlases can be seen. Next comes the spindle or the sclerosing rhabdomyosarcomas. They are the fusiform elongated spindle cells that show high degree of skeletal muscle differentiation. There may be collagen fluid to more collagenous fibrosarcomatous like area. They usually positive for again those muscle specific markers like myogenin, muscle specific actin. These are the things most commonly comes into the differential. CD99 and W positive may be seen. So they now started with the Ewing's group of tumors with a sheets of small round cells, then small round cells with the matrix or some amount of differentiation. Now comes to the next group where we can see the round cell sarcomas with a prominent sclerotic stroma. So there are 3 things in my hand. One is only small round cell tumor. Second is the small round cell tumor with presence of matrix. Third is the small round cell tumor with presence of some amount of sclerotic stroma. In this group, here comes the desmoplastic small round cell tumor. Here again, there are the neoplastic cell vary in size and shapes, most commonly affecting the abdomen and the retroperitoneal area. We can find the tumor necrosis or the spindle areas and the frequent mitosis among this tumor. This tumor usually shows cytokeratin, EMA or desmin positivity. The characteristic immunohistochemistry among these cells is the presence of WT1 antibody positivity, especially against the C-terminal ends. So there are the small round cells with the presence of a sclerotic desmoplastic stroma around these tumor cells. Their prognosis of these tumors is generally poor. Next, again comes the sclerosing epithelioid fibrosarcoma. It is a distinct variant of fibrosarcoma consisting of cords and strands of epithelioid cells in a densely collagenized matrix. Now these cells are cells having round to oval nuclei to eosinophilic cytoplasm. There is a high risk of recurrence among these tumors. They usually express the other fibrosarcomatous expression like MARK4. Focal weak expression of EMA may be seen among these cases. So after that, we are now moving to the next category. It's the round cell tumors with a prominent myxoid stroma. Where we can see in the picture, I have shown there are the small round cell component. Around with that, there is a variable amount of myxoid stroma component. Here comes the myxoid liposarcoma in the first component, which shows a typical lobular architecture with low cellularity at the center with the increased cellularity at the periphery of the lobules. In this image, the peripheral basophilia in the lobules is due to the hypercellularity of these tumors. There may be higher grade component of these round cells. There are uniform round ovoid non-lipogenic cells and the small lipoblasts at places. These high-grade tumors have a 5% hypercellularity area with the presence of a prominent myxoid matrix. The typical fusion transcript we see in this case is the translocation 1216 first DDIT3 fusion among these cells. The characteristic of this presence of lipoblast or lipomatous areas with a peripheral highly concentrated at the periphery, the round cells, and the center part with the hypercellular areas. Next comes the extraskeletal myxoid chondrosarcomas. Here again there are the small uniform cells with the round to oval nuclei surrounded by a condomyxoid matrix material. They show a multilobulated growth pattern. Okay, and they show usually ascended positivity among these cells, which will important point of diagnosis of these tumors. Next, one of the rare tumors is the mixed tumors or the myoepithelial neoplasm. They show a close resemblance with the myoepithelioma or the myoepithelial carcinoma of the salivary gland origin. It is usually non-extra soft tissue origin tumors, these myoepitheliomas. They show the typical EWS rearrangement in some cases and plaque 1 rearrangement cells in these tumors, and they show the characteristic epithelioid cells with the presence of a condomyxoid matrix around these tumor cells. Last on this group is the poorly differentiated sarcomas with the round cell morphology and the myxoid stroma. They are most commonly the poorly differentiated synovial sarcomas. They show the epithelioid to fascicular growth pattern among these cells. There may be hyper and the hypocellular areas. This doesn't show matrix areas. Next group comes the hematological neoplasms, comes the lymphomas, plasmacytomas, the granulocytic sarcomas. Here comes the immunohistochemistry plays a important factor here. The CD138 staining is strongly positive among the plasmacytomas. 4520 and CD3 differentiate those from the lymphoma group from those plasmacytomas. So LCS CD45 staining and negative for CD99 differentiated these small round cell tumors from the soft tissue to the hematolymphoid groups, then the further immunomarkers. For the granulocytic sarcoma, we need the myeloperoxidase CD34 lysozyme CD117 staining. Sometimes CD43 and CD68 helps to differentiate the granulocytic sarcoma from the other lymphoid tumors. Two of the important small round cell tumors I will just like to mention. As I said, I will touch with the some of the things. Among this, one of the is the neuroblastomas. It is mainly involving the retroperitoneum and the adrenal gland regions. They mainly arise from the neural crystals of the undifferentiated precursor cells of the autonomic nervous system, that is particularly the sympathetic system. Most commonly 70% cases occurs in the retroperitoneum and the adrenal glands. The tumor cells are composed of singly arranged small clusters, and they form small amount of rosettes, rosetoid arrangement of these cells. These are the undifferentiated cells with the high nuclear cytoplasmic ratio with the presence of a fibrillary matrix among the cells. There may be presence of rosettes and pseudorosettes among cells. This is the characteristic picture showing the rosetoid arrangement of these cells. Here, this is the undifferentiated cell surrounded by thin fibrocollagenous stromas, fibrocollagenous septus. This cell strongly express immunohistochemistry wise neuron specific analysis S100, chromogranin, PGP 9.5, INSM1. These are the group of tumors which are positive. They usually show endemic positivity among the cells. Next comes the nephroblastoma. I think it was better covered in the kidney tumor group. But I will just like to highlight it is a large abdominal mass presents with the hematuria and the pain abdomen things. So this is the kidney involvement of this tumor. Cytomorphologically, you can see this tumors as a blastomal component showing as a morphological similarity with the small round blue small round cell tumors with a round to oval nuclei with irregularity of the margin and the even distribution of the. Here we can see the blastomal and the epithelial component among the tumors with the presence of anaplastic features, giving it rise to the favorable and unfavorable histology. I am not going to details of this tumor because it is not a part of this discussion. Now next comes the. Here I will try to summarize all what I have seen. First group is the Ewing sarcoma, children and young adults affecting. Immunomorphologically, it is shows strong positivity for the CD99, NKX 2.2, FLY1, this group of positivity. Then comes the molecular genetics in the role. Then second tumor type is the round cell sarcoma with EWS-R1 non-ETS fusion. Here comes the role of CD99 and NKX 2.2, particularly NKX 2.2 is very common among this tumor. Then comes the CIC rearranged sarcomas. CIC rearranged sarcomas having again round to spindle shaped cells. They usually comes positivity with the WT1 and the NUT group of expressions. Next comes the sarcoma with the B-cord. Here the characteristic spindle cells with hemangious pericytomatous morphology. They comes positivity with the B-cord, SAT-B2 and the TLE1, then followed by the molecular genetics to confirm. Now after this Ewing's group, there comes the tumors with the others. Here the first two are the small cells osteosarcoma and the mesenchymal chondrosarcoma, where we can see the matrix amount. Next comes the rhabdo group, where we can see myogenic differentiation among these cells. Alveolar got a typical alveolar arrangement. Embryonal rhabdomyosarcoma has got a typical small round cell appearance. Then comes the stromal component with the presence of desmoplastic small round cell tumor and the sclerosing epithelioid fibrosarcoma, followed by the myxoid stroma, where we can find myxoid liposarcomas or the extraskeletal myxoid chondrosarcoma. So these are the common groups. I have made my presentation a summary of these groups here, and This is the initial panel of small round cell tumors which we use commonly to differentiate different things like CD99, NKX2.2, desmin myogenin for the this muscle differentiating tumors. Next comes the lymphoma groups with the CD45 positivity. Next comes the lymphoblastic TDT expression among these cells. Neuroblastomas will come with the INSM1 or the chromogranin positivity. Then any small cell carcinomas may also comes into the differential of the small blue round cell tumors. Desmoplastic small round cell tumor, one of this, and above and all thing melanoma comes everywhere. So again melanoma also comes into the differential of this. So this is the basic panel of markers which commonly we use as the initial panel for to differentiate the small round cell tumor in various categories. This is the algorithm to differentiate between the small round cell tumor of the bones and the small cell osteosarcomas and its mimicker. It's a very self-explanatory thing. We can go through this, but very naturally we can play with this thing, that is where we can see there are the expression of SATB2 Mark 4 will differentiate the different things with the other tumors. So finally, I am summarizing my lecture with the approach of this tumor. First up, on the basis of round cell pattern, it can be, if it is the diffuse round cell pattern, we have to think of Ewing's group of tumors. Other things that may come as a similar one, that is the Merkel cell carcinomas and the small cell carcinomas, lymphoma and the leukemia group in the differential, where we cannot see any of the stromal. Now, if we see the lobe, small round cell tumor with lobulated and surrounded by thin fibrous septa, then again comes the Ewing sarcoma group, also with the Rhabdomyosarcoma, particularly the alveolar variant comes in the differential. This is again the typical alveolar group where we can see the alveolar pattern of arrangement. Alveolar Rhabdomyosarcoma comes the first differential in this case. If we see good amount of rosettes, then we have to think of the neuroblastoma groups, the true and the pseudo rosette, the flexner and the homerite rosettes, and the typical characteristic rosettes will differentiate the neuroblastoma from the other. Sometimes we can see the hemangiopericytomatous blood vessel. Apart from purely differentiated synovial sarcoma and the mesenchymal columnar sarcoma, this will be again comes into the differential of this Beaker group of rearrangement tumors, which we have to keep in our. Then the round cell component with the other patterns like the pseudoglandular arrangement, particularly seen in the synovial sarcoma, or presence of cartilage or bone, where we will see the mesenchymal chondrosarcoma group or the small cell osteosarcoma group. We can again differentiate these tumors as per size, that is the small round cells for the Ewing spinette group, large cells with the melanoma, adenocarcinoma, lymphoid tumors, that comes in differential. And this is the differentiation as per basis of the origin of this tumor, which is very self-explanatory. Okay, so this way we can approach the small round cell tumors of the bone and soft tissue in the different. So after knowing this, if we judicially approach the morphology along with the immunohistochemistry findings and the molecular thing which comes later, with a proper decent histopathological approach, we can have a good sound sleep and a sweet dreams, and the nightmare of small round cell tumor hope don't appear again. So thank you again the Pursuit for giving me the opportunity to deliver these lectures, especially to Nadim sir for giving this opportunity, and thank you everybody for listening to this. So being happy is enjoying the happiness, and being sad is understanding what happiness means. So enjoy the happiness of the small round cell tumors, and keep this small morphological tidbits while seeing the slides, and try to apply while you diagnose these cases of tumors. Okay, thank you and good night.